think I'll go ahead and get our panelists introduced so we can get the session started. Thank you everybody for joining us today. We're going to talk about oligomets here. Our two panelists are Dr. Jeffrey Ryckman and Dr. Alexander Sherry, coming from West Virginia University and Mayo Clinic respectively. Myself, I am, here we go, Caitlin Ragland. I'm a PGY5 at UAB in Alabama and one of the ROVER resident moderators. So again, thank you for being with us today. And we are going to get started here with Dr. Sherry, and we're going to be covering oligometastatic prostate cancer.
Thank you so much, Caitlin and the ROVER team for the invitation. It's a delight to be here. Oligometastatic prostate cancer is something that continues to evolve month by month and year by year in terms of data availability. So I'll do my best to cover the basics in the next 20 minutes or so, but definitely feel free to interrupt with any questions. Certainly there's much debate in the clinical management of these patients. So we can advance to the next slide. And start with our first case. You have an 82-year-old male who presented a few years ago with an intermediate risk prostate cancer and had a radical prostatectomy, and now coming back in with rising PSA concerning for recurrence. You get some imaging, including a PSMA PET scan, and this reveals an avid right internal iliac lymph node, and in multidisciplinary discussion, this is felt to represent recurrent disease. And so the next question is, how would you manage this particular patient? So we can open up the poll. Would you observe this patient with active surveillance? Would you start hormone therapy or possibly even doublets? Would you do SBRT to this node? Would you combine SBRT with hormone therapy? Or would you treat the pelvic lymph node basins comprehensively with a more fractionated radiotherapy course? And would you consider treating the fossa? And would you add hormone therapy to that treatment? So we'll give it a minute for everyone to put down how they would at least think about managing this patient given the limited information presented. Okay, so it looks like 50% of the group here said they would do SBRT to this lymph node with some hormone therapy as well. And then another 1/3 recommended a fractionated radiation to the nodal basins, and that more kind of inclusive answer that may or may not include hormones or may not include the fossa. And there's really a trial to support all of these different options, and so we'll definitely get into that a little bit more. So going to the next slide, one thing that I think is sometimes a misconception is how we classify regional nodal disease. And actually, in much of the oligometastatic prostate cancer literature, because N1 is considered stage 4 by AJCC, many oligomet trials are looking at patients with regional lymph node recurrences in the metachronous setting. And this is quite different than how we might think about other cancers like lung cancer, where if there's a mediastinal relapse, we don't think about it as oligometastatic, but we think about it as still a kind of curative intent type treatment and paradigm. Two of the first trials in this space were the STOMP and ORIOL studies. Both had very similar designs. Both randomized patients with metachronous recurrence to either active surveillance or MDT. And in both of these studies, MDT, which stands for metastasis-directed therapy, was SBRT. That's also, I think, an important stopping point for considering what exactly the treatment is that's being given, because MDT is quite a general term, not only in terms of radiotherapy, which can include SBRT, as well as more hyperfractionated regimens or even conventional radiation given to metastasis, but also can sometimes include surgery or radiofrequency ablation. And so understanding the details of what that MDT actually is very important in interpreting these studies. For the STOMP and ORIOL trials, the most common site of metastasis was N1 disease. And so the patient we presented actually meets the criteria of both these studies. So we can advance to the next slide. And as most in the group here know, both trials did meet their primary endpoint. There were some differences in design in terms of powering and primary endpoint. STOMP looked at ADT-free survival, but in an updated analysis that was published in 2022 of both trials, we can see that progression-free survival was significantly longer with MDT shown in yellow compared to blue in observation. There has been some critique of these studies, although these hazard ratios are quite impressive. Glancing at the curves, especially within the first year or two, suggests that they're largely similar, although there are some patients, particularly in longer-term follow-up, who seem to do quite well with MDT alone. So naturally, the question has arisen, can we escalate therapy for these patients and potentially achieve longer-term disease control? So we can go to the next slide. The EXTEND trial asked this question. The EXTEND is a broader phase 2 basket study of multiple different histologies. Each basket was individually powered towards its primary endpoint, and EXTEND at its heart is a signal finding study designed to rapidly identify histologies where there may be efficacy of adding MDT to what is considered the standard of care. So unlike STOMP and ORIOL, which did not use hormone therapy, MDT's primary question was whether adding MDT to a hormone therapy backbone would improve outcomes in the form of progression-free survival. It's important to recognize that ADT has quite a bit of side effects as well as long-term sequelae. And so patients with metastatic prostate cancer, while they are routinely treated with ADT as standard of care, are often looking for means by which they might be able to de-escalate such therapies, which can impact quality of life as well as cardiovascular and metabolic outcomes. But nevertheless, prior to EXTEND, it really had not been shown in a specific randomized trial that adding MDT on top of ADT standard of care would improve outcomes, particularly in the hormone-sensitive setting. And so to that end, EXTEND did two different baskets, each with its own randomization. In the one basket, continuous hormone therapy was used, which is standard of care. And the other basket used intermittent hormone therapy, which was 6 months after enrollment, and then a break, primarily for quality of life reasons, and because intermittent hormone therapy is often used clinically in this population. This was a mixed group of patients, so 24% had castration-resistant disease. And unlike STOMP and ORIOL, and appropriately so, this was a cohort of more advanced disease, with most patients having a bone metastases, which is AJCC M1b. So we can go to the next slide. And first, the intermittent basket, we reported this a few years ago now, met its primary endpoint. The combined therapy showed significantly greater progression-free survival compared to hormone therapy alone on the left. A secondary endpoint was eugonadal progression-free survival, so getting at, again, whether patients who take a break from hormone therapy and then recover their testosterone, how do those patients fare in terms of either approach? And the EXTEND found that combined approach offered a longer eugonadal interval until hormone therapy needed to be restarted at the time of progression. We can go to the next slide. We recently reported the primary outcomes for the continuous hormone therapy basket. This also met its primary endpoint with significantly longer progression-free survival with combined therapy. The median was 48 months in the experimental arm compared to 24 months in the control arm, suggesting that the benefit of MDT is not necessarily modified by the use of an intermittent or continuous hormone therapy backbone. Next slide. One important question that has been raised is, well, given the outcomes we saw in STOMP and ORIOL, and given the interest in promoting patient quality of life in the setting of oligometastatic disease, which may otherwise be indolent, can we get away with just doing MDT alone, or do we really need this combination therapy? And so Radiosa asked this question and was also recently reported, randomizing patients with similar characteristics to either MDT plus 6 months of hormones versus MDT alone. The primary endpoint did show that clinical progression-free survival, which was largely based on RECIST and radiographic progression-free survival, was longer with combination therapy compared to MDT. Some have criticized this study by saying that ADT certainly impacts these things, and is this necessarily a surprising result? albeit the hazard ratios are quite impressive in this regard. But I think it very much is an important question. And I don't think it by any means that the question is necessarily answered as to whether we should give everyone hormones plus MDT. There may be patients, especially as we develop better tools for prognostication and prediction based on patient-specific characteristics, that may be very well suited with MDT or even serial MDT, as many on the call may be doing in clinical practice. So we can go to the next slide. Another recently reported trial that's very relevant to the patient in this case is the Peace v. Storm trial led by Piet Oost's group. This is, again, for metachronous pelvic nodal recurrence. These patients were randomized in a more modern setting with standardized PET imaging to either getting MDT plus 6 months of hormones or MDT and inclusion of the pelvis in an elective field with 6 months of hormones. Again, getting at that question of whether we should consider a stomp oral type approach with just MDT and maybe some hormones, or if we should be using larger fields, similar to how we might do so in another disease site. We can go to the next slide. And with its primary endpoint of metastasis-free survival, the whole pelvic radiation arm actually met its primary endpoint and showed improvements compared to MDT alone. Notably, this trial was powered with a one-sided alpha of 0.1, so the p-value does represent a significant difference according to how the trial was powered. And so, again, this data would suggest that although focal treatment alone is not an unreasonable strategy, the outcomes here are still quite good in the control arm. A kind of a maximal disease control perspective might favor a broader field in terms of that approach. Next slide. And so we can switch gears a little bit as there's quite a bit of data in the hormone-sensitive setting now to talk more about castration-resistant disease. This is the same patient who was started on hormone therapy at the time of recurrence and now has rising PSA that's progressing through ADT, consistent with castration-resistant disease. And you see this same radiographic presentation. So we can go to the next slide. There have been now 2 trials that have looked specifically at the castration-resistant population. One is the ARTO trial shown here. It was published a few years ago from multiple centers in Italy, randomizing patients to either standard of care, which was hormone therapy plus abiraterone, or adding MDT to this combination, and showed that PFS was greater with the addition of MDT to doublet therapy. The PCS9 trial was published this week and is very exciting. It had a similar design in terms of patient population and also showed that adding MDT to standard of care hormone therapy plus an ARPI agent improved radiographic progression-free survival from a median of 2 years to about 4 years. So again, all of this collectively suggesting that at least in terms of some of these early endpoints like progression-free survival, there's a benefit to adding MDT. Next slide. And so lastly, let's switch gears and talk about synchronous disease, whereas most of the trials, with the exception of Extend, focused exclusively on patients with metachronous disease. It's of some debate just how the biology and clinical presentation of synchronous versus metachronous disease presents. There's some data to suggest that synchronous disease, as one might expect, is much more aggressive in its behavior and needs more escalated therapy compared to metachronous disease. And so we can go to the next slide. And some of the questions about how to manage these patients have been looked at in several trials. In particular, whether to treat the primary prostate tumor. Many are familiar here with the Stampede ARM-H trial, which looked at adding radiation to the primary tumor in addition to standard of care hormone therapy across all comers. And then specifically also in a pre-specified fashion looked at patients with low metastatic disease burden. This trial was quite interesting based on suggestions shown here on the right that overall survival might be longer when adding radiation to the primary tumor. We can go to the next slide. More recently, the PEACE-1 study has reported And again, illustrating the fact that it's fun to keep up with the oligometastatic prostate cancer literature. And we have all of these great randomized trials now coming out that we can use to better inform our practice and future research. So this study, again, looked at de novo hormone-sensitive disease and randomized patients to one of 4 arms, either standard of care, which was ADT, and docetaxel was allowed, ADT plus abiraterone, standard of care plus radiation to the primary, or standard of care plus abiraterone plus radiation to the primary. Notably, in both STAMPEDE and PEACE-1, metastasis-directed therapy was not included as part of the radiation therapy regimen. So this is looking exclusively at adding primary site treatment. Next slide. There's a few major things to break down in the study. First, radiographic progression-free survival. Amongst the 4 arms, the intensified arm with abiraterone and radiation therapy had the longest radiographic progression-free survival. I think these results are quite interesting just in terms of how long that was achieved in the de novo metastatic setting. And if you're looking at those Kaplan-Meier curves, it's extending beyond 7 years in median in that intensified arm. That's not to say that standard of care plus abiraterone performed poorly. In fact, it also was quite good. And was significantly better than doing standard of care alone. And so certainly androgen receptor pathway inhibitors are an important part of the treatment of this population. We can go to the next slide. Overall survival, just one slide back, please. Overall survival was not significantly improved with the addition of radiation to the primary in either the overall population or the low metastatic disease burden population, which is shown in slide E. So at least in terms of the PEACE-1 study, compared to STAMPEDE, overall survival was not significantly different with that addition. Although, again, most patients, again, are still doing well 4 or 5 years following randomization. Next slide. 2 secondary endpoints that were fairly interesting. One was castration-resistant free survival. This was, in fact, improved with addition of radiation to the prostate in both the low metastatic burden population as well as the overall study cohort. Although this is, again, not overall survival or quality of life, the development of castration resistance is considered a sentinel clinical event in the management of these patients and transformation to lethal prostate cancer, requiring intensification and escalation of therapy. And so I think this is interesting by suggesting that radiotherapy impacts the natural history of this disease, even aside from addressing metastasis with local therapy. Next slide. Another important takeaway is a decrease in what was defined as serious genitourinary events like obstruction, which can cause eventual hydronephrosis and renal failure. These serious GU events were also lower in the arm that had radiation therapy to the primary. Next slide. And so this is a really great group, great graph rather, from a recent paper and seminars that I would encourage you all to read. The landscape of oligometastatic prostate cancer is rapidly evolving. And now with increased number of trials, it's beginning to take shape as to how we might fit in these different paradigms. But this management is very challenging. And all of these studies that we've presented, especially in terms of MDT, are phase 2 and really need validation. There are multiple ongoing phase 3 trials, which will provide more definitive answers to these questions. But for the time being, certainly you can think critically when you see these patients in clinic about what paradigm might best suit them in terms of not only PFS, but looking beyond that to think about toxicity and quality of life and longevity. Next slide. With that, I'd love to open it up to further discussion from the group or questions about oligometastatic prostate cancer.
If anyone has questions, they can certainly put them into the chat. Or if Dr. Ryckman has any discussion points as well, is a welcome. That's an excellent summary. And I really appreciate covering all of that data in one presentation. We're going to switch over. and move on to Dr. Ryckman's.
All right.
Let's see, there's
So,
one question we had as we're switching over. We can discuss how are we sequencing MDT and treatment of primary when patients present with a synchronous disease.
Yeah, Adam, thanks for your question. It depends a bit on some of the specifics. So it's not uncommon for a patient with de novo disease to present with a regional lymph node involvement and perhaps some pelvic bone metastases. And so if you're treating a prostate and pelvic field, often it's quite easy to grab those low bone metastases in your same field. And you can consider those for a synchronous or a simultaneous integrated boost. Some folks will treat with different sites, especially if you're treating more away from the primary field with SBRT if it's not overlapping during that primary treatment course. And of course, you can take some of the different regimens available, like the Stampede regimen, if you're treating only prostate in a bit of a de-escalated fashion. So you can consider, instead of treating perhaps to 40 gray in 5 fractions, de-escalating that a bit, or treating, if you're doing 20 fractions, instead of going to 60 gray, 55 gray. So I think it really depends, again, on what you're exactly treating in terms of how to think about managing the primary, the regional lymph nodes, and then any hematogenous metastases.
yeah, I totally agree. And to piggyback off that, insurance difficulties in the United States, there's a lot of times when it's not something that I can treat simultaneous integrated boost wise, primary and lymph nodes and bony mets, if it's not in the pubis or the sacrum or something, let's say it's in a rib or whatever, then sometimes what I will do to get around the dumb insurance things is just SBRT the distant sites first. And then almost always, if you repeat a PSMA, the prostate's going to show residual uptake until you treat it. So I know that, and I'll get a PSMA and be like, oh, imagine that, it's still active. And then I'll treat the prostate primary metachronously in the future. Because if you go for everything all at once, and they might say, oh, you have 20 treatments of IMRT, and you got to fit in the SBRTs with the IMRT. So it's a broken system. So long story short, sometimes I'll treat the Mets first, whatever's symptomatic with SBRT. And then 3 months later at their follow-up, then we'll get them ready to go for prostate primaries for folks that present with synchronous metastases. It's a little bit of a nuanced point, but once you're in practice, you'll beat your head against the wall for these cases that you go for primary and mets at the same time if you get stopped by EVICOR.
Great question, Adam. In terms of your question is, in terms of alignment, if you're treating, say, a bone metastasis, in the primary disease synchronously, I find in general, where often many institutions will align to bone first. And admittedly, if you're doing a little bit of a de-escalated regimen to the prostate, you can afford more flexibility in terms of your treatment. But usually, for low bone tumors, I haven't found alignment to be too much of an issue. That being said, you are also sometimes considering a nodal field. And so that may affect, either your dose or your PTV margins or how much escalation you're trying to provide. One thing that is important to emphasize in the management of all of these oligometastatic prostate cancer patients is that you're treating based on, some randomized data. It is limited. It's showing PFS benefit. It's not necessarily showing survival prolongation. It's not necessarily showing cure. And we don't really know, right, which patients will have significant benefit from this approach. And so you should be in your mind thinking in an isotoxic fashion and doing things in a way to really, maximize, again, patient safety and quality of life.
Yeah, totally agree. Textbook answer. Let's just say it's a Gleason 9, and you might micro boost it. You might not do 55 and 20. I tend to be more aggressive if it's like Gleason 9 and there's a dominant intraprostatic lesion without LUTs in these patients. So when you're matching to fiducials, that's when you have that rock forward sometimes. And for nodes, you might add 7 millimeters instead of 5 isotropic for PTV. You might add 7 sup and post, because it might cause your matching to rock forward a little bit because the prostate just tends to rock forward and back. So I would say the same thing might apply to bone. I've never come across that in my practice. but I might add a slightly more generous superior and posterior expansion for those cases where I'm microboosting. I tend to be more aggressive, but my patients do really well with microboost. And the only safe bet to do that on boards, I would say, is if it's like T3B, Gleason 9, someone you're worried about an isolated intraprostatic recurrence. But the safe answer is 55 and 20. Don't do microboost, don't match the fiducials, and then you don't have to worry about that ROC and differential PTV expansions. Okay, were there any other questions, or I guess should I get started? Okay, all right. So, well, I will try to share. I'm doing this from my computer. Let's add some last minute additions. Let's try that again. There it is. Okie doke. Let's move this stuff over here. Okay, perfect. So, hey, all, I'm Jeff. I'm an associate professor at WVU, and today we're going to talk about a complex adrenal metastasis case study and go into kind of the nitty-gritty stuff about technical approaches, and then also just some theoretical considerations for oligo SBRT. So there are my disclosures, none of which are really relevant to the talk, except for maybe cancerretreatment.org and Radon Calc. I don't make a penny from either one of those endeavors, though. So I guess we'll go to poll question number 1. So what is the grade 3 toxicity of oligo SBRT? 1.5%, 5%, 10%, 15%. What's late, acute, and late? All right. I might kind of end the polls. Okay, perfect. Yeah, we'll go ahead and we'll just end it there just with 10 responses. So half of people said 1.5%, other half of people said 5%. So essentially, it's really safe. The 95% confidence is at under 5%. So I mean, it kind of depends on what you're doing, median or less, or 95% confidence interval. But it's super safe, and our local control is like 95%. So primum non nocere, right? All right. And so here, what does this stuff mean? This is probably the most important thing to talk about. So if you look at different NRG protocols like BR002, they use 80% of the prescription dose to the OAR, right? This is not from LU002. It's from another study. I couldn't find it, but another one used 70% prescription doses minimum. But LU002, I like this so much better. Minimum acceptable PTV dose is what they do for this overlap with BAL. Of course, with CORD, you're going to be strict. But with like OARs, you kind of choose, what is your minimum acceptable PTV dose? And so we'll move on to the second question. And this is kind of a trick question, but what is your minimum acceptable dose to the PTV for oligo SBRT? So D99 to 98 is dose to 99 or 98% of the volume. That's called near minimum dose, okay? D100 is D minimum. And so it's common to see on templates for SBRT, D99 greater than 90%, but that's for definitive SBRT. You want the near minimum dose to be at least 90%, okay? But it really depends on the case for oligo SBRT. So for definitive cases, D99 to 98 greater than 90% is on some templates. But really, it's the minimum acceptable dose. The world is your oyster with oligo SBRT. Do no harm. That's really what the refrain should be for these cases. So, and here, patients are living longer and longer. Basically like the odds ratio of patients living longer is getting, by the year, patients are living longer and longer. That's essentially what it's saying, right? And so we keep getting better with staging, systemic therapy, and technology with radiotherapy. Patients are living longer and longer, so we have to be careful. They might see late toxicities. So key timeline of developments in oncology, all the red is in regard to systemic therapy. Huggins discovered androgen ablation, antimetabolite chemo introduced, and then nitrogen mustards in the late 40s. Combination chemo evidence in the early 50s, estrogen receptor discovered in the late 50s, and then tamoxifen in the late 70s. Trastuzumab in late 90s, IPI in 2011, Pembro 2014, osimertinib 2018. And then on to oncogenes. EBV is the first time a virus was shown to be oncogenic in the 60s. The SRC, it's like something to do with chicken sarcoma or something. That's the first oncogene. P53 was discovered. I don't know, something about RadBio. And then increased utilization of liquid biopsy-based assays in the 2010s to 2020s. From a radiology perspective, widespread adoption of CTs in the 70s and 80s, MRI in the 80s and 90s, and PET-CT in the 2000s, and then novel radio tracers. PSMA, by the way, Pluvicto, Medicare Part B, costs more than the entire specialty of radiation oncology. And then in the late 1800s, discovered X-rays, radioactivity, 1896. First time X-rays were used to treat breast cancer, 1896. Radium teletherapy came in the US and Europe. I'm sure there was the watch painters, in the 20s there probably as well. Cotard was able to cure head and neck tumors with fractionated radiotherapy. Our hands are forced to fractionate with archaic techniques. So we had to do it over many fractions. Lawrence won the Nobel Prize for the cyclotron in the 30s, first medical accelerator in the early 40s, advent of the SRS, Lexol invented gamma knife in the 50s. First LINAC in the late 50s, 3D planning in the 90s, Hellman and Weichelbaum, of course, in 95. Development of SBRT in the 2000s, cone beams in 2002. First patient treated with MR LINAC 2014, Sabre Comet 2019. And now modern oligo SBRT, our hands are no longer forced to fractionate. We can even do single fraction regimens for some patients. So let's go ahead and cut to the case. So we have a mid-60s patient who underwent a left radical nephrectomy and an adrenalectomy 5 years ago, presented with metagnancy oligometastatic renal cell, multiple courses of GK for brain mets and prior SBRT to the right adrenal, 40 gray and 6 fractions, which should raise an eyebrow to y'all here. Over 3 years ago, while on maintenance Nivo, so we did it concurrently after the dual immunotherapy. So brain metastasis velocity is 1 per year at the time of RT1 to the adrenal. Okay, so this is 40 gray and 6 we're going to talk about. Distant metastasis velocity less than half a met per year. Solitary right adrenal developed after 2 years. Excellent performance status. So what are we talking about here? Genuine oligometastatic disease. It's limited burden from diagnosis as opposed to inducible oligometastatic disease, which convert via therapy to oligo. So total consolidation of genuine oligometastatic disease may yield best outcomes. That's, it could be just prognostic. But that's what we're dealing with, solitary isolated lesion. So here the crosshairs are right on the adrenal met, and you can kind of see the duodenum is like super close. So I was sweating. I was fresh off the boat. I wasn't sure what to do with this. The ITV is getting 30 gray. The blue is getting 30, and then the red's getting 40. So the EV20, I only contour OERs within 2 centimeters of the PTV. So I just do an expanded volume, and then that way I just contour the OER on 4D that's in that area. Now on, I don't know if Nina's still here, but on her NRG protocol for pancreas, they contour all loops for that dose escalated pancreas study within 2 centimeters cranial caudal of the PTV. You can do that as well. That's textbook per NRG. But practically speaking, I only care about high and intermediate dose wash. So I just make my life easier and only contour the area around 2 centimeters around the PTV. There's an average in 4D. Average is just contoured on average 100. I don't have gating 30 to 70. So then the 4D includes all phases, so it's a little bigger. Same thing for kidney. Solitary kidney, patient highly motivated to avoid dialysis, you CKD 2. And so 25 gray is going to the PTV proper, 30 gray to the PTV minus a 5 millimeter expansion on OARs, and then 40 gray to centimeter outside. This is way too conservative. I was, now I'm comfortable to escalate 5 millimeters away to 40 gray or more. And then the ITV is in orange. So I just kind of wanted to show that just to see it did exactly what I wanted to do. Green here is 30 gray and red is 40. So it did exactly kind of as my contours wanted it to do. There's a 20 to 50 gray isodose wash, and it's VMAT on my TrueBeam. I could only do SBRT on my Trilogy at the time, so I just felt more comfortable with VMAT. Regimen, SBRT was denied too. So anyway, I just did VMAT IMRT with this. And so what's a commonly cited duodenal constraint for these 5 fraction regimens? Yeah, there's some tempting ones on here. 36 gray if you have an MR LINAC, that's also correct. But yeah, 30 to 33 is kind of the most commonly used. And so in this case, I was more conservative. I didn't want to do any harm, so I kept it at 25. And that's doing exactly what I asked it to, because the yellow, I asked it to do 25 gray, blue, 30, red, 40. Again, I think this is too conservative, and I was trying to do no harm, but I think I did harm because the patient recurred. So now she presents she had some avidity in the meantime, and so we switched her systemic therapy because I wasn't chomping at the bit to retreat. So switched her to Cabo and Nevo, and did serial PETs for like 6 to 9 months, put a needle in it, and it was biopsy proven recurrence. At this point, less than 3 brain mets per year, min max 1 to 6, and then distant metastasis velocity is less than 1 per year. This is her only extracranial met, so it's about half a met per year. So the adrenal twice over a 4-year period, essentially. And so how long to hold cabozantinib around SBRT? This is a really mean question. It's a VEGF, and it has VEGF. It's a dirty TKI, but it has VEGF properties. And just guess whatever. I had to look this up, you know. Perfect. So yeah, I guess some people are saying at least 1 half-life. That's about 2/3 of respondents. So here, there's kind of 2 different publications I go to. I'm also working with Dr. Guckenberger to develop a mobile application based on the Linux project that will tell whether or not to hold or deliver your radiation with SBRT. So there'll be a nice, great app sponsored by URTC that should be coming out in the next year. It will be evergreen. But here you can see 2 cycles is what they say for VEGF in terms of the experts from this study, or 2 drug half-lives is kind of on the longer end of what they may recommend. So that would be 10 days here. And then this study says for dirty TKIs targeting VEGF, at least 5 to 10 days pre and post break. So that's what I did, just 10 days on the more conservative end there. But really, those are my 2 favorite publications. These slides will be made available afterwards if people would like to reference them. But this is a big difference between RT1 and RT2, right? Like a half CM versus 1.6. I don't need to use any planning structures with this. I'm comfortable to escalate after practicing for many years. I'm comfortable to escalate half a centimeter outside of OARs, generally speaking, as opposed to 1 centimeter as I did initially. So we have so much room to work with here. So there's no need to do any of this fancy stuff where I carve out a 5 millimeter margin. So how do we account for prior dose? It's very challenging. There's no strong data to guide it. Consider the side effect profile of alternative treatments such as switching systemic therapy. Consider impact of the tumor progression in that area. So we need to get prior RT records. But what if we don't have them? For instance, in this case, I didn't care about the adrenal glands. We did 40 gray in 6 fractions, followed by 50 gray in 5 fractions. And some people say that great vessel should be limited to 120 gray. I knew we were going to blow that out of the water with 50 and 5. So I didn't give a hoot about the cumulative dose of the IVC. And also, there wasn't anything that was suggestive of a blowout in the IVC, like tumor encompassing the IVC, at least 180 degrees, for example. So anyway, let's do some hand calcs. We assume a worst case scenario. And I assumed 110% of the Dmax went into the IVC. So that's approach 1. Approach 2, we'll actually look at the values that were planned. So here, just assume 110%. Let's say it was treated at an outside facility. You should be able to do these re-irradiation cases even if you don't have the plan in front of you. So 44 is 110% of 40. And the EQD2 was 90 from the first RT. And then 110% of 50 is 55, and that's 154. So our cumulative dose is like 240 gray, which blows great vessel metrics out of the water, but I just don't believe in them. UPMC data for carotid is suggestive of that too. That doesn't matter. You can go above 120 gray EQD2. So we were almost right on the nose just with my estimates. So 97 was delivered, and then 168 for the second plan, right? So like you should know exactly what you're looking for before you even start planning. You don't even need the RT DICOMs, but always get them. I just make assumptions without even looking at the plan so that I crystallize what I want the plan to look at. And my re-irradiation plans rarely require replanning because I know exactly what I want, and I instruct dosimetry what I want to get started. And so anyway, I just thought that was a good exercise. And now we're stuck. Okay, here we go. Perfect. So you got to set the table for RT2. So you got to ensure a consistent nomenclature between the first and second courses so that the treatment planning system can perform dose summation. You got a consistent delineation between RT1 and RT2. So what I suggest is do an expanded volume of 2 or 3 centimeters and just contouring in that area in 4D. If you have an exploratory gating, you might be able to do the average 30 to 70, and that'll be okay as long as there's not much movement. If there's no gating, then I'd personally look at every phase. That's just me. So just ensure accurate rigid registration between RT1 and RT2. Don't get me started on deformable registration. I'm a medical physicist. Don't try to do deformable registration on your own. Tread carefully with deformable. And perform calculations based on EQD2 reserve. So you tell them For RT2, this is what I want, okay? So there's 3 different ways to do this. Use your metrics from the first course alone, which is nearly impossible to meet, especially if one course will exceed your metrics, like for the IVC in this case. No forgiveness method will use higher cumulative doses, but there's no real guidance on what to use for no forgiveness. And then for Michigan forgiveness, it's pretty well outlined. About 20% of their cases, they don't meet their own metrics for these plans, okay? So now this is cancerretreatment.org. I would really highly encourage you guys to play around on this. I know MD Anderson's using it, and it's going to be formally sponsored by Recog and things like that. So for the bowel threshold, 70 to 90 grade to D.1 cc is kind of what was the default for safe and borderline. No, I don't feel confident with these. I'm just saying this is what people use for MR Linux. They go above 90 grade UPD2 routinely without toxicity, but I don't have MR. And this just tells me that 22 gray, the Michigan method will say 19 gray, and then we're going to go with the more conservative of the two. But this suggests that 23 gray will get you an EPD2 of 70. That's super hot. And so now let's look at the Michigan method. 3-year interval, 25% forgotten to the duodenum. The duodenum is different than most other OARs, just like the stomach for Michigan. Everything else should have 50% forgotten if it's not duodenum or stomach. And it's 26.6 gray remaining EQD2 or 19 gray in 5 fractions, and they're really weird. They just want to be unique. They use an alpha beta 2.5. And so that's what I told my dosimetrists. I know exactly what I'm looking for, strict metrics here. And that's exactly what they gave me. There's clear check references here for forgiveness and no forgiveness. And no, I don't believe in any of these metrics. It's just convention. And so I just practice by convention. If it meets no forgiveness metrics and not, if it meets Michigan and not no forgiveness, I would like it to meet both. I want it to meet Michigan method and no forgiveness method. But if it meets one of the two, I sweat a little bit and usually accept the plan. If it fails to meet Michigan or no forgiveness, then I kind of go back to the drawing board. So I'd like for it to meet one of the two methods, preferably both, but know that Michigan didn't meet their metrics about 20% of the time for their reirradiation cases. And how do you counsel the patient in the face of uncertainty? That's the hardest thing, right? This is a solitary oligometastatic lesion. We're trying to prevent widespread progression, and she's highly motivated to avoid systemic therapy. So it made sense for her. So anyway, here I knew the math was going to work out. We're trying to aim for less than 70 gray. And what do we get? 43 and 45 gray. Piece of cake. There's a duodenum and duodenum 4D. I'd report both just because I'm OCD, because I treat aggressively. So I spend a lot of time on these cases. So the D1 0.1 cc is 17.4 gray, which is less than 19 gray. So I knew I didn't even need to look at these accumulated dose. I knew they're going to meet before I even check the clear check. Easy peasy. Same thing for Michigan, 41 gray as opposed to 54. It met it very comfortably. That recovery factor is 0.25. So if you use clear check, you just have to do a new clear check for every OAR with forgiveness, because it doesn't allow you to set per OAR forgiveness. And anyway, I'm kind of getting over on time than I planned to be. I had this down to 15 minutes, but I guess because we were a little bit short on the first session, I should be able to run through things quickly to allow 5 to 10 minutes for questions at the end. And so this is what we ended up delivering for RT2. You can see I did this on my trilogy. I had nightmares about 9 field IMRT when I first came to my facility, but now we have 2 true beams and we do VMAT SBRT. It is a beautiful thing. But step and shoot does a good job a lot of the time. And this, you can see here, 50 gray is comfortably delivered. And I was more comfortable with the dose wash into the kidney because I've been doing a lot more kidney SBRT. So even with solitary kidney, it can get 50 gray in 5 fractions, and you're not really going to have an EGFR decline. So I let it spill into the kidney a little bit more for this plan, whereas the first one, I kind of really pushed it. And I think that might have put us into a pickle because I think it might have recurred in the area that I avoided around the kidney. So anyway, that's what our 20 to 50 gray dose wash here. You can see I allowed a little bit more into the kidney this time around just because I was comfortable with kidney SRS. And then here is the duodenum here, but here it's just much more favorable. Remember, it was like 1.5 centimeters to the duodenum the second time around versus like 0.6 the first time around. So 20 to 50 gray dose wash of the dose sum, that's RT1 and RT2. This is terrifying dose cloud right here, 50 to 100 gray over 11 fractions. So I made sure I was OCD, and I had a positive sphincter clenching sign on the cone beams. Like every single time I checked, I made sure I matched slightly away from the duodenum if I could help it. And actually this setup was like beautiful every single day, but I don't have much to work with that 50 gray isodose line over 11 fractions. That's no bueno. I think that's a little bit higher than 33 gray over 5. But regardless, now my med onc wanted to do a PET CT. I was like, let's not get it. Let's just do CTs. And there's some avidity there. And I'm like, okay, there's going to be more avidity in 3 months, and I'm not going to want to put a needle in it. You know what I'm saying? It's radionecrosis at this point. So, okay, so just some theoretical, and the patient's doing super well. She had terrible ripple and diarrhea with cabozantinib, and she's just on Nivo maintenance alone. So we're going to kind of rinse and repeat for her. Again, this is metastatic colorectal, but she's 5 years out now and doing very well. No side effects except for on her systemic therapy. Am I worried about IVC blowout? Did I counsel her on that? Absolutely. But I said, we know what's going to happen if we don't do anything. So we weighed that risk of IVC blowout to a certainty that she would die from this if we don't do anything. Theoretical considerations for this is, this is a simple math problem, exponential growth of tumors. So we need to re-explore the oligometastatic paradigm, because in the treatment of cancer, in the treatment of patients with metastatic cancer, the current paradigm states that targeted treatment of metastatic lesions does not prolong life. But when it comes down to the arithmetic, it's actually a pretty simple concept. The NC here is the effective cell kill. Radiation has a high effective cell kill. If we treat earlier, like on this green line here, then there's going to be a benefit in terms of getting to the same tumor burden without treatment versus with treatment. It just takes longer the earlier you treat, And so from here, survival depends on quantitative parameters: slow tumor growth, more effective cell kill, such as radiation or, systemic therapy or whatnot. Lower tumor burden or earlier interventions at lower tumor burden stages. So we need to reframe our questions based on these factors, and not whether, if it works, but how and when it works best for patients, right? So brain metastasis velocity pace is not very well understood. These patients got repeat SRS, second, third, and fourth course. If they had less than 3 spots a year, they lived longer than a year. So if you have a low brain metastasis velocity, you have a better prognosis. Remember, our patient was less than 3 mets a year, but she had 1 year where she was 6, but we still treated her then, and she went back down to 1 met the next year. And then distant metastasis velocity as well. I love Willman's group. They did less than half a met per month. So instead of brain mets per year, it's distant mets per month. And those patients usually live longer than a year, even with low, intermediate, or high. And they seem to break out among these groups. These are two. One of them is like a registry, and the other one's like a prospective study. So lower distant metastasis velocity, better outcomes. Then the impact of distant metastasis velocity on widespread progression. Here, it was statistically significant that patients with a low distant metastasis velocity, less than half a met per month, took longer to develop widespread failure, which is more than 5 mets at the same time. This is extremely valuable to delay polyprogression. I tell my patients who were doing rinse and repeat SBHT on, they're on borrowed time. Sure, they might have an indolent cancer, but avoiding systemic therapy switch and the ability to do high dose SBRT, those are beneficial. And I think these patients are living on borrowed time. And then same thing, if you don't have local control, then you're more likely to have widespread progression. So why wuss out with 20 gray and 5, when you can deliver higher doses safely using modern technology? So that's just my bias, is total consolidation, whether synchronous or metachronous. And then what are the implications on dose selection here? That's the thing I struggle with the most for my frequent flyers. I have one I'm seeing next week, I think I've probably treated 15 times, although she was polymetastatic to begin with. So it's kind of playing around with 25 and 5 like doses or lower, sometimes 8 and 1. But dose selection is something I always struggle with, especially for those patients that might not be genuine oligometastatic. I'm less aggressive in inducible oligometastatic patients, especially when I'm treating the liver, for example. And then risk stratification. Most patients in the middle get systemic therapy alone. And then if they're high volume, aggressive cancer, elderly, poor performance status, they might go early hospice, whereas maybe we should be more aggressive with these other patients. But we're still learning how to define them. And there might be a role for M1 widely metastatic. The ARREST trial showed it was feasible, and ARREST-2 is ongoing right now. So maybe there's a role, for M1 widely metastatic. And then the NRGCC014 study, I believe, is asymptomatic bone met study. So PACE, the low disease burden and slow growing tumors may not be associated. They're often associated, low disease burden and slow growing tumors, but the correlation may not always be consistent. Dr. Chang had an excellent paper just on pace of disease, and that we still have so much to learn, such as tumor doubling time or specific growth rate. PSA doubling time is one as well. We talked about BMV and DMV earlier. And so there's ways to do this, but we need auto segmentation to quantify this stuff for us. We have a lot to learn, right? So if we have an auto segmentation, it'll be helpful. And this needs to be part of our vocabulary. Brady metastases and tachy-metastases. Pace of disease is super important. So if you want to sound like a smart resident, you should say that. And your attending might think you're making words up, but they're definitely words. Okay, practical considerations. There's still so much to learn. We need to use tumor markers, biomarkers. They have a controlled primary. What's their response to systemic therapy? How many lines of systemic therapy do they have remaining? Is it genuine or inducible oligometastatic disease? The number and volume of metastatic lesions with AI and auto contouring, will be better at defining volume. And then this is for later. You guys can look at that on your own time. I always kind of struggle with, in particular, patients at risk for obstruction with central tumors. I try to do endobronchial debulking and 3 months of systemic so that I can deliver a higher dose later on. But that's just hard. Patients at risk for symptoms if you watch them for 2 to 3 months on systemic therapy. So when do we go? But anyway, what's the role of local consultative therapy? And we just have 3 more slides left to maintain current systemic therapy. So if you have 1 or 2 sites progressing, then radiation allows continuation. Bunch of studies here. Extend, I would say on the continuous subset, it allowed folks to not be escalated on systemic therapy. And despite variations in all these designs, all these aforementioned studies notably extend duration of current systemic therapy by about a year at least. I think that's meaningful for patients. So negative study curve and extend breast wasn't really negative for systemic therapy switch though. That was positive to delay systemic therapy switch, but it was negative for PFS. And curve breast, it included a lot of inducible oligometastatic disease, and those patients had like 4 to 6 lines of prior treatment. Very different than Radiant or Avatar, which are earlier on in the lines of treatment. So sure, for breast, it may not extend PFS, but it does extend duration of current systemic therapy. So if they're tolerating it well, that's a meaningful benefit of patients, even if they're breast cancer. At local consultative therapy in lieu of systemic therapy, the MD Anderson renal cell study just was published, I think today. Chad Tang just tweeted about it. He did rinse and repeat up to 6 times, and those patients were systemic therapy free. Crazy. Rinse and repeat SBRT, systemic therapy free in 90% of patients at a year. The UT South or the MD Anderson, no, it's the UT Southwest cohort. That one didn't have long follow-up, so we don't know the median time is like 28 months without systemic therapy, as it was on the MD Anderson Chad Tang study. But regardless, there's lots of exciting data here for LCT and lieu of systemic therapy. And then for systemic therapy holiday, extend prostate, the intermittent cohort, I think was a good example of that. It's a good insurance policy to feel more comfortable with systemic therapy holidays. So basically, final thoughts of future of oligomets treatment. Ongoing advances in systemic therapy, imaging, and radiation are driving improved outcomes. Patient discussions must clearly address risk, benefits, and expectations, particularly with repeat radiation. So how do we counsel these patients in the face of uncertainty? That's the hardest thing with re-irradiation. Best practices for dose summation with and without recovery factors, they need to be standardized. So this is a critical skill to counsel these patients. You have to build rapport, lifelong relationships with your patients. And then clarifying the PTV prescription. When do you compromise coverage, and when do you change your dose, your minimum dose to the PTV? It's really an art more so than a science, I think. And then looking ahead, quantifying pace, personalized risk stratification, and biomarker guided decisions. So I went way over. I hope that was useful. Are there any questions?
Yeah, I know we covered a lot, and like you said, we'll make sure both he and then we will also publish a link to the slides in addition to this recorded session if you want to share with anybody else as well. But yeah, we have time for a couple questions, and I'm going to also share our next session as well as we take questions.
Thought that was a good case because I had cold feet, with how I planned originally, and it really put me into a pickle. And I told the patient at the time, this is probably gonna be the only time I'll be able to get away with 50 gray and 5 to an adrenal met after initial SBRT.
Sometimes I think that patient also had a previous left adrenalectomy. I get endocrine involved, with concern for adrenal insufficiency down the line.
Yes, yeah, I meant to put that in. I need to add some slides on that. She was referred to endocrine, absolutely. Yeah, because the other adrenal was taken out, and this one obviously is not functional. Yeah.
I think that's a great lesson too, the perspective of an early practitioner as you gain experience going forward.
By the books though, like, 30 and 5 to the PTV with, I mean, that should have gotten control over half the time, so I'm not beating myself up about it. I just didn't want to harm her by, overdosing the duodenum or something. So I think it made sense to be conservative. I don't know if I would have changed anything about the initial plan there. Yeah, these are tough cases, right? Like primum non nocere. So then how do you choose your dose in those situations?
Excellent. If there's no additional questions, then I'll just say we do have the next session is going to be just after Astro. It's going to be October 3rd, focusing on adaptive, sponsored by Varian for their Ethos machine. And we're going to have 3 excellent panelists to join us for that. Okay, if there's no additional questions, then thank you all for joining, and we look forward to seeing you all soon.